Hello, hello. My name is Jill Osborne. I am the president and founder of the Interstitial Cystitis Network. It is Sunday, November 4th, 2018, and it is time to do an IC support group meeting. So, my purpose in doing these meetings is to help patients be strong, confident, knowledgeable, and ready and willing to have good, proactive discussions with their medical care providers. So we're just going to wait a minute or two, let people come in. Hello, hello on YouTube. I see you. Very, very nice to see you. Hello, Facebook. It's nice to see you too. We're just going to give some people an opportunity to come back in. Give me 1 second. I got to go do something. Hello, everybody. It's Jill from the IC Network. We're here to do an IC support group meeting. Sorry about that. I'm telling you, some Sundays you really just want to relax and, get over the stress of the week. And I don't know about you guys, but I had a wicked busy week last week, characterized by working 5 hours last night to do our IC Network newsletter. So I have to kind of organize myself. Hello, Lou. Hey, it's nice to see you from the United Kingdom. Welcome. Hi, Karen. It's very, very nice to see you too. Hello, Donna. Jirai, Guy, you know what? It's killing my eyes. If you're not seeing me over there, it's because my eyes are freaking out right now. I have a lot of eye strain from working on the computer. So if you're not seeing me over where we normally assemble, that is because my eyes have been in pain. So guys, we're going to do an IC support group meeting today, and I am hoping that Facebook cooperates this time and shows me your messages. So if you're on Facebook, could you please go ahead and post some messages there so I can see if it's scrolling correctly? Because I'm now sitting in front of 4 computers to try to make this happen. It's absolutely crazy. I have a lot of important things to talk about today too. So, but I've got to check this one computer here. All right. Hello, Brenda. It's very, very nice to see you. We got 6 people over on YouTube. That is great. Hi, Gladys. It's nice to see you too from Louisiana. Hey, Jerry. Very cool that you're in San Diego. I have a lot of people in San Diego in my family. I spent a lot of time down there. San Diego is also home to the University of California, San Diego, which has been one of the premier IC research centers in the United States. That is the home of Dr. Lowell Parsons. Dr. Lowell Parsons is really a godfather of the IC movement because he has developed a couple of very, very important things for us that we use over time. You may know him mostly for his invention of Elmiron, but he also invented the PUF questionnaire, which is the hallmark diagnostic tool that, it's working, yes. The PUF questionnaire is the hallmark diagnostic tool that OBGYNs use to distinguish between bladder pain and pelvic floor pain and bladder wall pain and reproductive tract pain. And what that's doing is that's saving a lot of women from completely inappropriate hysterectomies, which tragically happens. One of the things.
Diagnostic.
Hold on. That's one of the other computers. Hold on. Turn this computer off. This.
And reproductive tract pain. And what that's
Stop
doing
it.
is that's saving a lot of women from completely inappropriate hysterectomies.
Look at that.
Tragically happens. One of the things.
Hold on. All right, Dad, here's your computer. Oh my God. I'm serious here, guys. I gotta tell you, listen, I am not a computer geek. When you watch the IC Network live sessions, you're going to see a comedy of internet stuff. Between the computers and making Facebook work and YouTube work and Facebook malfunctioning and all that sorts of stuff. I apologize in advance if it looks like it's not smooth because sometimes it's just not smooth. All righty. So, hello, Donna. Yeah. Hi, Dale. Hi, LaWayne. It's very, very nice to see you. I'm so happy I can actually scroll through. Hello, Emma from Australia. Hello, Brenda. Hi, Donna. Oh, I'm so glad Facebook is working right now like it didn't work last week. Hello, Faith from South Carolina. Tabitha writes, she talked with me on the phone a couple of weeks ago, and she had the Microgen next generation DNA test done, and she's feeling much better with esterase and pelvic floor physical therapy. And because of the DNA sequencing test, you were finally able to get rid of your urinary tract infection. Yeah, baby. That's what we like to see. That's what we like to see. You know, I want to, I have to say that one of the things that continues to happen, hello, Dale from New Mexico. It's nice to see you too. I have been getting a ton of phone calls from patients with infection, with UTI. And, normally we associate interstitial cystitis with a lack of infection. And in fact, that's kind of the hallmark, is that when you go in with symptoms of frequency, urgency, pressure, pain, and they cannot find an obvious cause of that pain, specifically infection, then usually what that means is that they've instead got bladder injury or pelvic floor injury or something like that. And, we talk about the IC subtypes. We've got five subtypes for IC, which we've talked about before in our online meetings. We've got Hunner's lesions, bladder wall injury, pelvic floor injury, neurological injury, and central sensitization, right? So these are our core patient groups with interstitial cystitis, these 5 variants of IC, okay? So but as Dr. Christopher Payne talked about when he proposed these subtypes, is that there are subtypes. So in bladder wall driven, for example, we see potential different causes for bladder wall driven injury or symptoms. So what do we know that can injure the bladder wall? Chemical exposure. That's a given. If you've gone through chemotherapy, if you're drinking diet soda every day, if you are exposed to harsh chemicals, we know that those can irritate the bladder wall. That's a given. We know that. The second thing that we're going to look at with bladder wall symptoms is going to be menopause. Because if you're struggling with estrogen atrophy, what that means is that your bladder does not have that nice normal protective coating that it has when we're younger. If you think about it, the bladder is the only organ in the human body designed to hold toxic waste. So how does it hold toxic waste for hours at a time and not be damaged? Well, the bladder is like your mouth. It is a hollow organ covered with mucus. And it is this nice wet barrier that acts to protect the skin of the bladder from the chemicals in your urine, right? And so this is a 3-dimensional picture of the bladder wall. And you can see at the top, we have a layer of mucus, we have a layer of cells, and then underneath that, we've got nerves and blood vessels. And so what happens over time is this coating for a woman gets thinner and thinner and thinner because we don't have as much estrogen. So there's a problem with that. Okay. So as it gets thinner, look what happens. The irritants in urine can penetrate through to the bladder wall and cause irritation. Now, this is the epitome of what happens with a diet-induced flare. So if you've eaten something that's a strong acid, you've got these acid irritants, or if you're a smoker, you've got these irritants in your urine that are penetrating through down here and causing irritation. However, this is also a way that infections can happen, because this nice protective mucus also acts as a barrier to bacteria. And when you don't have a lot of mucus, guess what? you don't have a lot of protective coating. Thus, not only is it easier for your bladder to get irritated, but it's also easier for you to become infected. And that is indeed why there is a really solid subtype in IC subtype bladder wall driven that is, in fact, potentially chronic infection or infection. And, you know, if you followed the IC network for years and years and years, you know that I have always been receptive to the concept of infection, but I have a pretty rigorous standard, you know, because we have a lot of patients who have self-medicated. Every time you have a flare, you self-medicate with antibiotics, and that is really, really dangerous. And we don't want you to do that. What we want to find out is, do you have infection? And if you do have infection, can we please treat it correctly? So as an example, I was working with a young woman on Friday who, when she was in college, got an infection. And you know what? She never went to the doctor. She didn't go to the doctor for months. And it was getting worse and worse and worse and worse. And I am absolutely convinced that one of the reasons why she's got a fairly significant bladder issue now is because she had an untreated infection for many, many months, if not years. So again, we're dealing with all these phone calls now. So why are so many people getting infections, bladder infections? Well, the other thing that we really have to understand is that bacteria are getting better at defeating infection. You know, there's this kind of perception, and I know that some of you out there have gone through this, where, you know, there's this assumption that the reason you have a bladder infection is because you are not clean. You know, and you get the little whispers, hey, maybe you're not wiping, you know, make sure you're wiping correctly, front to back, all that sort of stuff. And there's just this kind of really terrible shaming that's going on with people who get recurring infections. Like, maybe you're just dirty. Well, guess what? We now know that you can get bladder infections from meat. From meat. There was a very interesting case several years ago of hundreds of college students in Washington, Idaho, and Oregon who all got a really rare bladder infection. I mean, it was a very unusual, rare bladder infection. So as they were trying to solve this issue of why all these college students got it, they were able to trace it back to a slaughterhouse. And it was a slaughterhouse that was selling meat to university commons. So that's evidence number one, that you can get a bladder infection from food, and it has nothing to do with your cleanliness at all. Now, you may have heard a couple of years ago about the dreaded superbug. You know, if you've been paying attention at all, you know now that because antibiotics are so grossly overused in people, but more importantly in animal products on feedlots and stuff like now, that we have created this incredibly robust and difficult to treat infectious breeding ground, antibiotic resistance in a breeding ground, right? And up to this point, usually there's been a bacteria that will kill even a resistant infection. But several years ago in China, they discovered a new E. coli that was resistant to everything. And it was found in people around a pork farm. And so they were obviously buying meat from this pork farm in China, not knowing that those pigs were so massively over-medicated with antibiotics, they had grown a quote-unquote superbug. And so you had all these people in China who got this infection. And it was really quite scary for those doctors because the typical routine antibiotics didn't kill it. So everybody was watching China, right? And that's something I'm very interested in because I was on the U.S. Army antibiotic resistance panel last year, and did one of my graduate projects on the isolation of drug-resistant bacteria in hospitals. So it's kind of a really strong interest for me. So anyway, here we're watching China. It's like, what the hell is going on with this crazy infection? Then it occurred in Europe. Took about a year or two, and it arrived in Europe. And people in Europe were getting bladder infections from pork products again. And again, this is pretty scary. So we're all just hoping and praying it didn't make it to the United States. Well, guess what? About 4 years ago, it finally arrived in the United States. And it arrived in the United States in a woman with a bladder infection. And she was like in Pennsylvania. And she had not traveled. Normally, you would pick up these really drug-resistant infections from traveling. Like if you go to India, India is a terrible problem with antibiotic-resistant infection because antibiotics are over the counter. Okay, so in this case, here you've got this woman with this really wicked bladder infection, the big one that they were scared of, and she's alive, guys. They were eventually able to treat it. But one of the questions they asked her is, have you been traveling? Have you gone overseas? And her answer was no. So they started doing some digging. And you know what? They found it in pork farms in the United States. Pork farms in the United States. So the assumption is that she got this very drug-resistant bladder infection from eating a meat. And so whether it is chicken or beef or pork, it is absolutely in our best interest and your best interest to make sure that you're buying your meat products from a local farmer where you know that they're not raised with antibiotics and that they're grain-fed, not meat-fed, et cetera, et cetera. I'm assuming you already know most about this. So I think the last time I looked, there were like 4 or 5 people who had gotten this drug-resistant infection, and they basically just had to throw a massive combination of antibiotics at them. They all survived, but it was hard. It was a truly wicked bladder infection. So the question then becomes, why are people getting more bladder infections today? Because I'm telling you, I'm getting phone calls almost every day now from someone who has picked up a drug-resistant, usually E. coli infection. And my only guess is that we're seeing it coming from food, because I really, truly believe that y'all aren't dirty. Hello, Bobby. It's very, very nice to see you. If you have tested positive for infection, at least twice this year, and more importantly, if it's the same infection over and over and over again, if it's E. coli every single time, then we have to be open to the possibility that perhaps you picked up one of these foodborne E. coli infections. And as it was just written here in one of our chats, one of our members just said that she did something called next generation DNA testing, where they were actually able to find the bacteria and, more importantly, find the right combination of antibiotics to kill that specific infection. You know, and again, you kind of get stuck in this thing where you're going to the doctor, he's testing your urine's testing out negative every single time. It's like, what the hell is wrong? Why is my bladder screaming? What you may not know is that a traditional urine test simply does not isolate most of the bacteria that can be in your bladder wall, or you could have a fastidious infection or a low-grade chronic infection that a typical aggregate urinalysis will not find. So what do? You do something called next generation DNA urine testing. And what this does is, rather than throwing your urine into a little agar plate and seeing what grows, they actually look for DNA, bacteria and fungi, candida, in your urine. Remember, too, it was the MAP Research Network, the National Institutes of Health Research Network. The National Institutes of Health funded a multidisciplinary approach to the study of pelvic pain network, which is our key IC research group in the United States. They're the ones using this. They're the ones who found that our bladder often contains an overgrowth of candida during flares. So this isn't some patient online saying, hey, maybe it's Candida. This is federally funded IC researchers who have absolutely found Candida and or other potential bacteria in your urine. So if you're one of those people where you keep getting infections or you think you're getting infections over and over and over, the slam dunk test to see if you really are having infection is this next generation DNA testing. And it's only $199. Now, I got to tell you, 5 years ago, this was thousands of dollars. This technology is why we know that urine is not sterile. This technology is teaching us about the urinary biome. This technology has shown us that there are 70 species of beneficial bacteria in the bladder. The bladder is not a sterile organ. And so using this next generation DNA testing, we're really trying to, or coming to understand more about how the bladder thrives and how it works and what bacteria do and all that sort of stuff. Very cutting edge stuff. So this is what patients and doctors are now turning to if they think you've got a funky infection. And the cool thing about this is it will show you everything in your urine. It will show you good bacteria, it will show you bad bacteria, and it will show you fungi. And it will also show you any antibiotic resistance genes present in the DNA in your urine. So I had mine done last spring, and I've talked about it in previous lectures. And what's so interesting about it is it showed that I had a drug resistance to aminoglycoside medications. And I have never taken an aminoglycoside. Never. And I can only assume that I acquired this drug resistance gene probably from some sort of food product. So I think that that's really the biggest theme that I'm seeing in our office in the last 3 to 6 months is we're just seeing more and more patients who are calling who really do have infection. And it's not related to their IC. I think it is relating more to some changes in some of the foods that we're eating. And my suggestion to you, given what we know about the superbug, is I really would not be eating big national chain meats where you know they're grown in giant hog farms or cattle farms. Because again, that's where antibiotics are used the most. I'm not against meat. I eat meat all the time, but I get my meat from a local butcher or a local dairy or something like that, where I really know how they treat it, and I know that they're not using antibiotics in creating this. So that's trend number one. Trend number two is we are getting more and more patients calling who have taken Elmiron for a long period of time, and they are now showing eye damage. And we released that in August, and where we had researchers from the Emory Eye Institute report that they believe that they have discovered a new eye disease related to the long-term use of Pentosan. So we have been sending out warnings about that. I am working with the FDA, submitting our data. I've got 700 patients now who participated in our research study. For those who have taken Elmiron, 53% report eye disease. 53%, not 5%, 53%. Now, granted, that data can be massaged and there may be genetics involved for some of those patients, but it's big enough and significant enough that it's a pretty big deal. And I'm now filing a citizen's petition with the FDA where we are formally requesting a review of Elmiron and requesting that they look at this research and perhaps send out a warning asking patients who are taking Elmiron to have eye exams annually. That's my goal. I don't want to take Elmiron off the market. It helps a lot of people in IC subtype 2 bladder wall driven. However, it is important for any patient taking Elmiron who is noticing any changes in their vision to make sure that they get their eyes test, because we don't want you to have permanent eye problems, there are options to Elmiron. I can get into that a little bit more, but let's go ahead and take your questions. So I'm going to come to YouTube. So I've got Facebook up here and I got YouTube down here. So if I'm looking down, it's just because I'm looking at YouTube. So BTE, it says, he's the boyfriend of a person with IC and it is considered a severe case. My question is, how do they find comfort for the future? There never seems like there's a light at the end of the tunnel. Any coping methods? Okay, so BTE, this meeting is so much for you. I cannot begin to tell you. You know, we are long past the days of thinking that IC is, quote, an uncurable bladder disease. We don't think that anymore. And the reason why we don't think that anymore is because we now understand, and research has proven, that structures outside of the bladder are often involved, and in fact, sometimes heavily involved. And so BT, now what we're doing is something called subtyping. We want to know what unique variation of IC your girlfriend has so that we can focus the right treatment at her. I use a subtyping system. So subtyping has been going on now for about a decade around the world. In Europe, there are 16 subtypes, and they're based on biopsy results. In Canada, they use the U-point system and the input system. Their urology guidelines are focused around subtypes. In the United States, we don't have a formal national agreement about subtypes yet. However, I use the subtyping system that was created by Dr. Christopher Payne, who ran the IC research program at Stanford University for 25 years and is now in private practice with his wife at Vista Urology. Vista Urology is the premier pelvic pain center on the West Coast for anybody on the West Coast. So let's go over these subtypes real quick. IC subtype 1, Hunner's lesions. Now, everybody in the world agrees that this is a different disease group. Why? Because when we do biopsies of their bladders, we find profound inflammation. And inflammation means that your bladder's fighting something, right? Inflammation is kind of the sign that your body is at war with something. And the rest of us do not have the massive levels of inflammation in their bladder wall that patients with Hunner's lesions have. And so there's a very strong movement to move Hunner's lesions out to its own disease group. And I agree with that. And pretty much everybody in the world agrees with that. The reason why we haven't is because, at least here in the United States, is because we've worked so hard to educate people about IC in general that if we start pulling people out of that IC diagnostic criteria, it could jeopardize their treatment. Okay. But anyway, Hunner's lesions. Hunner's lesions are treated and respond best to lesion-specific therapy. This is the patient group who often struggle the most with pain. And the reason why they're in pain is because lesions have not been treated correctly. Lesions do not respond to a bladder coating like Elmiron. Lesions need lesion-specific therapy like cauterization, fulguration, a steroid injection. And we now have the first treatment in history that has healed Hunner's lesions in just 2 weeks. It's called Liris. And so this patient group, long considered to be the worst group of IC, now have a treatment that can heal their lesions. Unfortunately, that's still in research and we're still waiting for that. Okay, so that's IC subtype 1. IC subtype 2, as I mentioned earlier, is bladder wall driven. So these are the patients whose symptoms are originating from their bladder wall. And usually it's some sort of injury. So we know it's coming from the bladder wall if they have pain as the bladder fills with urine that is relieved by urination. So the fuller you get, the worse you feel. And as soon as you pee, you feel a lot better. And if we take a look at, I can explain why that happens. So here is a picture of IC subtype 2 bladder wall driven. So what we can see here is that this bladder is incredibly irritated. Now, imagine urine filling this. So urine fills it higher and higher and higher, and urine is getting into all these wounds. And so you feel worse and worse, and it's like, ow, ow, I need a bathroom. Now, where is the bathroom? And then as soon as you pee, bam, urine is no longer touching the wounds. Thus, you feel much better. So that's how we know your bladder wall is driving your symptoms, is if you have pain as your bladder fills with urine that is relieved by urination. And in this case, again, we have subtypes. So there might be chronic a chronic infection. It's a small group. We know Lyme disease can come and sit in the bladder wall. So that's a possibility. We know that there can be viral infections. So infection is one small variant of bladder wall. But again, we also have menopause. We also have, far more importantly, just simple basic chemical irritation. So again, BTE, one of the things that I would want to know about your girlfriend is she still drinking coffee? Is she still drinking soda? If she is, that would absolutely be provoking this and making it very, very difficult for these wounds to heal. All right. I see subtype, here, hold on. 3 is our biggest subtype, and this is our curable subtype. Chris Payne wrote when he developed his proposed to subtypes, he said, it is so unfair to tell patients this is incurable. This is not incurable. There are some subtypes that can be cured. And that is, in fact, this subtype. So these are the patients whose symptoms are being driven by muscle injury. So if your symptoms began after a fall, after a car accident, after having a baby, after if you were a victim of rape, of sexual abuse, or if you have a history of athletics like ice skating or anything like, or gymnastics or ballet, anything that put pressure on your pelvic floor, or if you were in the Army and you were a paratrooper and you did a lot of parachute jumps that traumatized your pelvic floor, or if you are a triathlete where you're sitting and training for long periods of time on those pelvic floor muscles, this in fact is pelvic floor 3. Now, in this case, what we see is instead of pain as your bladder fills with urine, these patients often have pain after they're done peeing. But there are other hallmark symptoms. One of the issues with these patients is it's hard to pee. It's hard to start your urine stream. Your muscles are so tight, it's hard to let urine out. So look, here is your pelvic floor, right? So these are your nice pelvic floor muscles that go from left to right, front to back, low to high. And what makes your pelvic floor muscles so interesting is that it's the only really major muscle group that actually has holes in it that control other bodily functions. So in your pelvic floor, down at the base, you've got holes for urine and holes for your uterus if you're a female, or your vagina if you're a female, and holes for your rectum, right? So what happens if these pelvic floor muscles get injured and tight? Look at this. They go, ooh, they tighten down and they get tight here. And guess what? It's hard to pee when your muscles are tight. So you're often waiting 5, 10, 15, 20 seconds for your muscles to slowly relax so that you can pee, right? You might feel a sense of heaviness, a downward sensation. Or in my case, I used to have an upward sensation, like somebody was shoving a funnel up my urethra or up my vagina. However, after my surgery last year, I had hysterectomy for uterine cancer. I had levator spasms for months. And it was like there was a hand up my vagina pulling it down. That was how my body interpreted a pelvic floor spasm. For these patients, now realize you have no clue that you have an injury. Let's just say, let's consider the paratrooper that I worked with a couple months ago. So he was in his, I'm going to say early 40s, and was really struggling with what we would consider symptoms of IC, frequency, urgency, pressure, pain. And they had first put him on antibiotics because he was diagnosed with chronic prostatitis. Nothing helped him. Then they told him he had overactive bladder. Nothing helped him. Then they told him he had IC. Nothing helped him, right? And so here he was really, really suffering. So he calls me and we're just kind of like talking. And I'm like, so have you ever had any bad accidents in your pelvis? And he goes, well, yeah, I was a paratrooper, and I went, okay. So when you landed, did you ever fall on your butt? And he goes, many times. And then as we were kind of going through the other symptoms, it was really crystal clear that in fact he had a really serious pelvic floor injury. And so we sent him off to physical therapy because obviously for him, IC treatments aren't going to work. His fundamental problem are tight muscles that are making it difficult for him to pee and that are compromising blood flow and stuff like that. So what I can tell you about this one is muscles require muscle work. You're not going to take a pill to fix a muscle problem. And if you got my newsletter last night, I sent out a newsletter last night. My self-help tip is all about, don't be afraid when you go to the physical therapist if it hurts the first time. When they send you to physical therapy for a pelvic floor assessment, their job at that very first appointment is to study your body. They're going to look at your legs. They're going to look at your glutes. They're going to look at your hips. They're going to look at your belly. They're going to look at your back. They're going to have you walk up and down the hallway to see if you're walking weird. They're going to measure your legs. Is one leg longer than the other? They're looking for obvious signs and patterns of muscle dysfunction. And then, yes, they are also going to do an internal exam. For women, they're going to do a vaginal exam. And for men, they're going to do a rectal exam. Because remember, your muscles are up here and they're down here. So they have to use a finger to get up and touch them to see what's going on with them. Now, what we know for many patients is it hurts. All of a sudden they're touching and then they touch something and you go, that's it, right? But because you're the patient, you're going, oh, hell, I'm not going back. I don't want to get hurt. But you're completely missing the point, because in that first appointment, if they can touch something and reproduce your symptoms, that is a spectacular success. You know why? Because it means they found it. They've touched it. They know where your problem is. So you don't let any pain from that first appointment stop you from going back. That's their job, to find where it hurts. It's okay. Because when you go back the second time, they know what they're working with now. They know the muscle group. They know how to work with it. And they're going to be much more gentle. Okay? So with pelvic floor driven IC subtype 3, if you've got tight muscles, you have to do muscle work. Our objective is to take your muscles from here to here and to restore blood flow so that your bladder can get the proper oxygenation and nutrients that it needs to be healthy. Okay? And if you haven't signed up for our newsletter, I did send it out last night. You can go on over to our website and sign up for it. It's pretty cool. All right. IC subtype 4 is pudendal neuralgia. Okay? So these are the patients who have the equivalent of a nerve injury. And so their symptoms are often very positional. They're fine when they stand, but when they sit, it screams. Or when they bend over, it screams. Or when they squat down, it screams. Movement triggers their pain, and it's nerve pain. It's electrical pain. It's like sciatica. Okay? And so this is one of the smaller subtypes. I have a partial pudendal nerve entrapment. And for me, it flutters. It's like sitting on a cell phone. In fact, it's doing it right now as I'm sitting here on my left butt cheek. It doesn't hurt. It will only hurt if I sit here for a long period of time. But it's like a little tiny quivering of the nerves, right? Like sitting on a cell phone on vibrate. Okay, why is that happening? Because I have a muscle that is pressing a nerve. And so for these patients, our treatment of choice, number one, is pelvic floor relaxation so that we can stop those tight muscles from squeezing a nerve. And then number two, we're going to do things that are calming and soothing to nerves. And so this is a subtype where interstem neuromodulation actually might be helpful. Urgent PC might be helpful. Sometimes they do nerve blocks with this, or sometimes they might actually go in and surgically release the nerve. There is a birth defect that sometimes happens in your pelvis. It's a highway. It's this highway of stuff going all these different directions. And so again, we got your pelvic floor, and there are gaps in your pelvic floor that blood vessels and nerves go through. And there's one gap that normally one specific nerve goes through, and sometimes you're born with it missing the gap. And so sometimes they go in and they surgically repair that. Okay. So I see subtype 4, pudendal neuralgia. I see subtype 5, central sensitization. Now, this is the subtype that's most often inherited. This is my core fundamental subtype. So my sister, my mother, my grandmother, my aunt, my cousin, this is characterized by having a very sensitive nervous system. So we have very sensitive skin. Like literally, I just ordered something and I have to take it back because the seams bug me. We tend to be drug sensitive, where a normal dose of a medication is too strong for us. We need a half dose or a pediatric dose. We tend to be food sensitive. There are some foods in our body that just simply don't work. For me, it's oatmeal and chocolate. They don't kill my bladder, they kill my bowel. We're just sensitive to stuff. We tend to have a wicked sense of smell. We can smell things that other people can't smell, and smells really drive us crazy. It's so interesting that smells can provoke pain, but for somebody with central sensitization, they do provoke pain. And so for this one, what this means is that we have been born with a sensitive skin. We've got a sensitive stomach. We've got a sensitive bowel. We've got a sensitive vulva. We've got a sensitive rectum, and we've got a sensitive bladder. And a lot of this is just related to genetics. You know, remember, our body was designed for life 5,000 years ago or longer. And if you ponder the concept of evolutionary adaptation, what that means is that species adapt over time to new stressors. So the fastest cheetahs survived because they could catch food. The slowest cheetahs died because they couldn't catch food. The fastest gazelles that could run away from the cheetahs survived. The slowest gazelles died because they were caught by the cheetahs. We know that animals adapt over time to stressors, but it takes about 5,000 years for an evolutionary adaptation to occur. So we have to kind of go back to our heritage. So as an example, I am 95% Scandinavian, Swedish and Norwegian, with a little bit of Finnish and a little bit of Western Russia, okay? 5,000 years ago, what my ancestors were up by the Arctic Circle. What were they eating? They were eating the world's blandest diet. They were eating fish. They were eating deer. They might have been eating whale. They might have been eating berries and salt. There was no coffee. There was no tea. They might have had roasted acorns, but there was no coffee. There was no green tea. There was no black tea. There was no citrus. There was no oranges in the Arctic Circle. For thousands and thousands of years, it is only the onset of the international marketplace today where we are being introduced to foods that perhaps our body does not have a lot of defenses for. Somebody, for example, who is of Spanish lineage or who grew up around the equator, they have been eating acidic fruits for tens of thousands of years. Their body knows how to process and protect itself from acid. Hello, my little body from Norway is designed for life in Norway. And so we could argue from an evolutionary standpoint for me that my body sorted out, my body is based on life in a less acidic climate. And also we can suggest that sensitivity was selected, that we needed to be sensitive, that we needed to have a really good sense of smell to find food, or to protect ourselves from bad food, or maybe to sense a predator. But clearly, sensitivity is nurtured in certain lineages, you know. And I wish we could go back and figure out why, but we can't. Okay, but the reality is it's our foundation. We're sensitive, and you know, one of my pet peeves is how people weaponize the word sensitive, especially with children. They say, oh, you're just sensitive, get over it. Well, you can't get over being born sensitive. We have a different nerve. We have a lower action potential on our nerves. Our nerves fire with less stimulation because that's the way genetics built us. And so to tell somebody that they need to get over it is completely unfair. Instead, what we have to do is we have to respect that sensitivity. And the odds are, if you have central sensitization, you've already completely adjusted your life. You just may not know why. So you're probably not using any scented candles in your home because you can't stand the smells. You're probably not living in the city. You're probably living in suburbia or the country because it's a quieter, more peaceful, and a less stressful environment for you. So central sensitization is not a disease. We don't think of it as a disease. It can certainly happen after injury also. So if you sustain some sort of major traumatic injury, that also can cause the nerves to become more sensitive. And our job is, in fact, to protect that nervous system. You don't fight it. So in my case, one of the ways I protect my nervous system is to avoid caffeine, because caffeine is a jackhammer to the nerves. And hello, my nerves are sensitive. So somebody asked here on YouTube, well, can people have multiple subtypes? And the answer is absolutely. Okay, so I'm IC subtype 5 for sure, primary. That explains my life. Thank God. I thought it was all my fault in my 20s. I now know it's not. It's a gift of my ancestors. But I am also IC subtype 3 pelvic floor injury. So, and then my bladder is secondary. If my pelvic floor gets messed up, my bladder gets messed up. But most of the time, it's really just my pelvic floor that is my treatment target. Getting back to, let's see here. Hold on, I'm just scrolling up here to BTE. So you are the boyfriend of a girl with IC who is really struggling and is really worried about her future. And I want to tell you right now, there is tremendous hope. We're no longer forcing patients down the one treatment fits all Elmeron. We know that doesn't work. Now that we're subtyping, we're finding better treatments and we're getting people better quicker. And there is tremendous hope, including potentially cure based upon her subtype. All right. Sorry, that was kind of a long answer, my friends. I apologize for that, but it is what it is. Lisa asked, what are the symptoms of chronic bladder infection? Are they different from what a typical UTI feels? No, they're the same. One of the really interesting things about, I give you a lesson in E. coli. There's a guy, I think he's at the University of Iowa. His name is Scott Holtgren. He runs an E. coli research lab. And I attended a lecture he did quite a few years ago talking about how E. coli can defeat antibiotics. And E. coli is really an amazing bacteria. One of the things that it does is if it senses a white blood cell, and your white blood cells are the cells which kill bacteria, right? When it senses a leukocyte coming, a white blood cell coming, it changes shape. It becomes a noodle. It becomes a long, skinny noodle. And because it's a different shape, the white blood cells can't find it or they don't recognize it. So that's one thing that E. coli does. The other thing that E. coli can do is it commits the equivalent of bacterial harikari. So when it senses a threat like antibiotics, sometimes what it does is it basically kills itself. It takes little pieces of DNA and it wraps it in a little piece of cell membrane, the equivalent of what we would call a bacterial seed. So if you've got a small but deep bladder infection and it senses the antibiotics, it's going to try to protect itself. So what it's going to do is it's going to create little seeds of, I think it's RNA rather than DNA, wrapped in a little bit of cell membrane. And they're passive. They're not active infections at all. And so the antibiotics come in, clean anything, kill everything out, but they have no idea that these little passive seeds are there. And then it's our body's own healing process, which turns the seeds back on. And so then you get infection. And so we have in research studies with women who get recurring infections over and over, they have studied their urine, they've studied their vaginal secretions daily to try to figure out what the pattern is. And there are women who, one day their E. coli is there, 2 or 3 days it's not there, the next day it's there, 2 or 3 days it's not there. And that we think is related to these seeds kind of becoming active and then getting silent, becoming active and getting silent. I'm sure there's a much more academic explanation for that. The last lecture I saw with him was probably 5 years ago, and I'm sure there's new things going on. So don't quote me on that. That's what I got from his lectures years ago. Remember, the other hallmark for chronic UTI is you tend to see, or any UTIs, you tend to have a lot of urethral burning, which is not necessarily consistent in somebody with bladder wall-driven symptoms. Okay. Dale says he has Hunner's lesions. All right, so Dale, so the question then is, number one, have the lesions been treated correctly with fulguration, with steroid injection, or with Lyris? Now, if you're a man, they have not adapted the Lyris device to go down a male urethra, but they are working on that. So in the meantime, because you have bigger wounds in your bladder, you've got to really try to protect them. And that means you have anybody with Hunner's lesions, man, diet is everything. You would be very, very foolish to be drinking coffee or soda when you have an active open lesion. Dale asks, will insurance pay for the DNA urine test? Yes. If you go to bladderhealth.org, they will give you more information on that when you go into order. And it is possible even Medicare can pay for it. A little bit longer to get it done, to get paid. But that said, it's available. Dale, also, remember now, we've had multiple studies now which have also isolated viral infection in the urine of patients with Hunner's lesions. We've got a study that has found the polyoma BK virus, another study which is found, just released 4 months ago, called the Epstein-Barr virus from mono. And one of our questions is, why do Hunner's lesions recur? And so we now have a possible new method of action. It might just be a viral infection. So one of the things, Dale, that you could do is you could call Microgen. If you go to bladderhealth.org, you'll have a link over there. You can get their phone number. They actually have a viral screen. And it's like, why not? It might be interesting. It might be interesting. One of our members, Gail Ben Shabbat, is going over to the ESSEC meeting in Europe at the end of this month. She went last year too. Her daughter had IC, and that's one of the questions that I'm asking her to ask the Europeans is, how are they treating viral infections? How are they identifying viral infections in the bladder, and how are they treating them? The use of an antiviral is interesting, but it hasn't been studied. But it's interesting based upon these findings. All right, let's go up to Facebook here. Jerry says, Dr. Parsons diagnosed her 1 million years ago. Okay, so it was Tabitha, who I said earlier, I read her message, that she did have the DNA urine test, and they were finally able to get rid of her urinary tract infection, that she's feeling much better. So that thrills me. I am so happy for you, hon. I just think that we're much more vulnerable to infection now in the last couple of years because of the food that we're eating. Amanda says, why does my bladder hemorrhage when you have a cystoscopy? Easy. Your bladder is a hollow organ. It's like your mouth, right? It's like your stomach. So you know what happens when you eat too much and your stomach swells? It hurts like hell, right? Because, let's just say, because your bladder is like a balloon, right? So when there's no urine in it, it's pretty small. And then as it gets fuller, it expands and expands and expands and expands, right? So this might be your bladder full. But when they put more fluid in your bladder than what your bladder is normally adapted to, so they stretch it more, it ruptures blood vessels. And that's why your bladder can hemorrhage when you have a cystoscopy. Now, there's a difference between a hemorrhage and, well, there's a petechial hemorrhage. So these little red spots, these are examples of petechial hemorrhages. So these are often the result of the bladder being stretched, and which is why hydrodistension is no longer the gold standard diagnosis for IC, because we now know that when you stretch the bladder, it will spontaneously cause these red spots. But there are some people who have a lot more red spots, which shows that their bladder is also massively inflamed. Okay. All right. So that's why, you know, your bladder has limits. When you stretch it past its limit, the little blood vessels are going to rupture. Hello, Nancy from Boston. Hello, Stacy. Cheryl, my question is, why does my IC feel so much better the week of my menstrual cycle? The week prior to my period, it acts up. Okay, hold on. I want to make sure. Why does my IC feel so much better the week of my menstrual cycle? The week prior to my period, it acts up. It's all about estrogen levels, my dear. Remember that for a woman, we go through a very clear estrogen change. As you start to ovulate, and when you ovulate, your estrogen levels are very high. And then when you're having your period, your estrogen levels are very low. And hormone levels can influence how your bladder feels. Normally, patients will flare the day that they ovulate because that's a real extreme level. So that, you know, 4 to 6 hour flare the day that you ovulate is very routine and normal for women. And then you usually feel better when your period starts because your estrogen levels are you're normalizing again. But we're different, you know. I mean, again, getting back to these subtypes, I see subtype bladder wall. I think that there's a very small hormone subtype in there too, because I've worked with a lot of patients over the last 25 years whose hormones are just off, and we don't know why. They're just off. And when they get their hormones regulated, their bladder improves. And that's never been studied. I believe that if I'd won the lotto, believe me, we'd have a research foundation and we'd be studying that right now. All right. Stacy says, is there a correlation between having a small bladder and IC or IC pain? Boy, that's an excellent question. Okay, so I'm kind of like looking at it from two different perspectives, right? So can somebody be born with a smaller bladder? Sure. I mean, you know, our human body as it grows in many, many different ways. Some of us are tall, some of us are short. Some of us have big bladders, some of us have small bladders. But the question is does it correlate with IC? And what we can say is that when the bladder is profoundly irritated, I mean, gosh, I'm trying to think of a way to explain this. If you have repeated cauterizations for Hunner's lesions, what happens is it leaves scar tissue. And scar tissue does not expand like normal bladder tissue. So people who have had a lot of cauterizations are going to find that their bladder is probably going to be quote unquote smaller and have a smaller bladder capacity. But I guess the other question is there some sort of pathology in the bladder wall itself that can lead to a smaller bladder? And I don't know, but something's wiggling in my brain. You know, I read so many research studies, and I just got something is at the tip of my brain about this. It might come to me. Let's look at this for a moment. So remember, this is a three-dimensional picture of your bladder wall. So we got the mucus, we got your normal epithelial cells, and then we've got underneath the blood vessels, and we've got nerves. And, you know, one of the mysteries of kind of the bladder is, how do these cells move and stretch when the bladder gets bigger? You know, I mean, like we know when we know how muscles work, right? So a normal relaxed muscle is like this. But when you contract it, the fibers slide like this. So it's a smaller muscle, but it's a harder muscle. It's a firmer muscle, right? And then when you relax that muscle, it goes like that. So you've got muscle in your bladder, but you've got smooth muscle in your bladder. So that's a possible mechanism there. And there may be something there too. I'll think about it. That's a really, really good question. I might even ask our medical board about that. I like that question a lot. Hello, Debbie. Always nice to see support group leaders in the room. Hey, listen, I don't care if you were a support group leader 20 years ago or you're a support group leader today. You are my heroes. I'm a rebel because I always believe that the support group leaders are literally the heart and soul of the IC movement, because we're working with patients. And that makes me a rebel, because I don't believe that money should go to national organizations as much as I think money should go to support groups. All right. Sarah, my doctor suggested hormone replacement therapy to see if it settles my bladder, but didn't suggest estrogen cream. Have you heard of HRT helping the bladder? At this moment, I don't know if my IC issues are due to hormones or perimenopausal. There is absolutely no doubt that hormones influence your bladder health, because hormones directly influence the production of mucus. So when you're young and you have a plentiful supply of estrogen, you have a plentiful supply of mucus. As you get older, you have less estrogen, you have less mucus. And so that is what eventually can lead to something that we call the genitourinary syndrome of menopause, where you've got a tender bladder, a tender urethra, and a tender vulva. So what do we do to treat that? We usually use a hormone cream. When you're taking a hormone by mouth, you are putting it through your bloodstream. It is being distributed throughout your body. It is going to your breasts. It is going to your ovaries. It is going to your uterus. It is going to your vagina and your cervix. And I am living proof that there are serious ramifications to taking oral estrogen, AKA my uterine cancer last year. I had early uterine cancer year, and I had only taken oral estrogen for like 4 years. And I thought I was safe because we have no history of any estrogen-driven cancers in my family. No one has had any breast cancer, cervical cancer, ovarian cancer, or uterine cancer in my family. Like, leave it to me to be the one, right? Like I said to my doctor, why me? Why me? I thought this was genetic. And he said, no, we don't look at it as genetics at all. It just means you've got cells that are turned on by estrogen. So, Sarah, I think you really need to have a really good discussion with your doctor about the risks of using oral estrogen, because the risks of using topical estrogen cream are far less. And when you use an estrogen cream in your vagina, it will cross to your bladder and help your bladder, but you're not getting the secondary effects of it potentially triggering some breast cancer or stuff like that. Lisa says, I keep getting the icy belly when I have a flare. Why does that happen? That, my friend, is usually a sign of inflammation. So what's funny about it, all right, so, it's so funny that you can wake up with a flat, not that mine is flat right now. Hello, menopause belly. You can wake up with a flat tummy, and then you're like out to here hours later or by the end of the day. And we asked Dr. Theoharides of Tufts University why that happened. And he believes that that's really just kind of a temporary inflammatory process, or kind of a reaction. Your body's reacting to that flare, maybe a self-defense mechanism. What we do know is the belly goes away and then it comes back, and then it goes away and then it comes back. And so one of the things that I see patients generally learn is that it's pretty good to wear an elastic waist. Yes, that is my post-hysterectomy menopause tummy. All righty. Christy, if you think you have subtype pelvic floor during a cystoscope with hydrodistension, will they still see bladder wall bleeding? Probably, because we know the procedure will cause that. Anytime you stretch the bladder, you're breaking cells and blood is going to happen. That is, again, why hydrodistension is no longer the gold standard diagnostic method used for IC. Instead, what they could do is something called an anesthetic challenge. So if we're trying to figure out what the integrity of the bladder wall is, we're trying to figure out if the bladder wall is healthy or not. Does it have holes in it or not, right? So it was Dr. Lowell Parsons who invented the potassium sensitivity test. Because if you put salt on a wound, it hurts. And of course, so if you put potassium into a wounded bladder, yeah, you're going to be pretty unhappy. It's going to hurt like hell. But the potassium sensitivity test fell out of favor fairly quickly because it hurt so much. And so it was Dr. Robert Moldwin, the author of the IC Survival Guide, who said, hey guys, you don't got to put salt on it. All you got to do is put lidocaine in your bladder. And if it turns off the pain, then yeah, that's a de facto diagnosis that your pain is coming from your bladder. It's from your bladder wall in some degree. And that's kind of, again, a de facto diagnosis that that your bladder wall is the source of your pain. So, Christy, rather than a hydrodistension, what they could do is an anesthetic challenge, which would be less traumatic to your bladder in general. Again, if you read the AUA guidelines, they only say a hydrodistension should be done if the diagnosis is in doubt. If they don't know what's going on, or they think you have a Hunner's lesion, or you're bleeding a lot. Man, if you're peeing blood clots, yeah, you got to have a hydrodistension. They got to figure out what's bleeding. But it's just not done as much as it used to be done. Christy says she's given up caffeine completely and all trigger foods, but you still have constant pain and you have an icy belly. So, Christy, the question is when is your pain the worst? Before you pee or after you're done peeing? That's what I would want to know. Angie says, is there a correlation between IC and stomach acid and continuously getting ulcers in the back of your throat? Doctor just started cimetidine in a GI cocktail. Diet is key, but not doing it for me. Also have a UTI. You know, here, hold on a sec here. What's so interesting about a lot of those early studies for IC is they verified IBS, but they never really asked about stomach distress. And but when you hang out in an IC group, what you find is a lot of people have a lot of stomach distress. They either have GERD, or they've got gastroparesis, or they've got gastritis. So we did a survey years ago where we surveyed patients and asked them, do you have stomach issues? And like 90% of IC patients said that, yeah, they had stomach issues. Don't quote me on that, but we can look it up. I've got the data behind it. I just, off the top, I mean, it was a pretty high amount. Almost every IC patient said at one point in time they had, or they were continuing to have consistent stomach issues, myself included. I had several bouts of gastroparesis and GERD early on before, or gastritis and GERD before I was finally diagnosed with gastroparesis a few years ago. So, you know, it doesn't surprise me that you're having issues. And if cimetidine helps, if a low acid product helps, that's good. But, you know, we kind of have to look at the other, the other elephant in the room, and that is our urinary biome and our bladder biome and our bowel biome and our stomach biome. Could we all be having stomach and bowel issues because our normal good beneficial bacteria is been harmed? If there is any patient group that is going to be vulnerable to what we call dysbiosis, it's going to be a urology patient like us, because what do they throw at us? Antibiotics constantly. Before you're diagnosed with interstitial cystitis, the odds are you've had several, if not many, if not years of taking antibiotics. And that takes a toll on our gut. And our gut needs good bacteria to function healthily. So that would be something else, Angie, I think that would be worth kind of exploring is are you having dysbiosis? And I would talk to your doctor about that, your doctor about gut health, maybe following a FODMAP diet. It would be very interesting to see if reducing your FODMAPs helped a little bit. What they're finding with IBS is that the FODMAP diet is what's really helping. That's FODMAP. So I check that out and maybe consider trying some of that too. Ooh, Debbie says she had bladder infections for 2 years and was eventually diagnosed with a urethral diverticulum. The surgery was very helpful. So that's for, Debbie, that's really interesting. So you guys, I don't know if you've ever heard the term diverticulum. It's a little tiny tube. And sometimes we get little tiny tubes connecting things that are not supposed to be connected. So we can get a diverticulum between the vagina and the rectum, or between the urethra and the vagina. Things can happen, and what that can do is that creates a really easy tunnel for bacteria to pass. I was working with a patient, I think last year, who they found a giant diverticulum in her. Most of her pain was urethral. So think about it. Your urethra is basically the size of your little finger, right? She was having a lot of urethral pain, and they just couldn't figure it out. And they kept saying she had IC, and she was doing all the treatments. And she went to a new doctor, and it was a nurse practitioner who was like really listened to her and said, because she kept saying, it's right here. It's right at my urethra. And the nurse practitioner ordered a different type of MRI that revealed that underneath her urethra was, in fact, a diverticulum, almost the exact length of her urethra. So she had a tube that was filling up with urine, and the urine was staying there, and she was getting infections in it. And so when they actually, because think about it, they basically did like a 3-dimensional MRI. And when they looked at it from the front, they saw a tube above her urethra, the length of her urethra, and it was in fact a diverticulum. They surgically removed it, and she healed, and she's symptom-free now. So, it's not always generic IC. We have to really, we have to listen to your symptoms. You have to verbalize as often as you can any weird, unique symptoms that you have. And in her case, she kept saying, it's my urethra, it's my urethra. And they kept saying it's referred pain from the bladder. And she's like, no, it's here. And she finally got somebody to look at it, and they found it. Okay, so your ability to be persistent and to describe anything unusual is really important. Follow your gut. Follow your gut. I don't like it, at least with myself, because I have had a lot of medical anxiety in the past, especially associated with my bladder. And so it's very kind of normal for me to want to avoid testing. But when I avoid testing, I worry obsessively. And so like I did when I started bleeding last year, which was early uterine cancer, I blew it off. I didn't want to have a biopsy. I didn't want to do that. I had bad memories of stuff like that. And look at where it got me. 6 months later, they found it, and that could have been the difference between my life and death, but we caught it at the right time. So, don't let your fear stop you from having a test. Amanda, on your 3rd kidney infection this year. So Amanda, again, you are the perfect candidate for next generation urine testing, especially if you've been in the hospital, because hospitals are the most common source of these super drug-resistant infections. Hello, Corrine from Belgium. It's very nice to see you. Karen says, other countries won't export our pork. Yeah. Regina just gave really, really good advice to Angie about watching her potassium levels while taking any acid reducers. Yeah. Okay. Has anybody, Norma asked, now this is an interesting question. Has anybody had a flare from a flu shot? I had a flu shot 2 weeks ago. I don't think I've ever had patients call to say they flared from a flu shot until this year, because I did have somebody call me about 10 days ago who had a flu shot and had a pretty wicked flare from it. So I'd be curious, did anybody else have flares from flu shots? Let me go back down to YouTube here for a moment. Isabella asks if someone has Hundred's lesions, would they have elevated CRP in their blood? I don't know, hun. We can look it up for you. If you want to email me, we can look it up. I mean, I've got the books. The books would probably tell us that. I just don't know off the top of my head. Lisa White asks, would irritations in the pictures only show up with a hydrodistension versus a plain cysto? Many patients have completely normal cystos. I had a completely normal cysto when I was diagnosed 25 years ago. However, if they do something called narrowband imaging, which is a new, much more refined video of the bladder, they can see more, including lesions, just during a cysto. Also, Beaumont Hospital in Royal Oak, Michigan, the #1 IC research center, Beaumont Health, they have now invented a new lab test for Hundred's lesions so that we won't even have to maybe even do hydrodistensions anymore. And that is, they presented their data last spring, and that's looking very, very good. It's having a new test where patients won't have to have hydrodistensions at all to find lesions. But hey, listen, guys, you know, there comes a point where your local doctors simply are not solving your problem. And that's because many local doctors just don't have a skill set, the skill set you need for kind of advanced aggressive pelvic pain. And that's when we refer people up to regional doctors at your local university. So you go from local doctors to regional doctors at medical schools. But even some medical schools are good and some are bad. I will tell you, one of the places we rarely, if ever, refer patients is to any Mayo Clinic. Mayo Clinics have been historically terrible for IC. A lot with a lot of guilt that it's all in your head and all this sort of stuff. At that point in time, we always suggest going to a national expert, because it's the national experts who have seen thousands of patients, who have seen interesting trends, and who are really master diagnosticians. And so there are several national experts out here in California. It would be Chris Payne at Vista Urology. It would be Phil Hanno at Stanford. In the Midwest, it would be Ken Peters at Beaumont Health in Royal Oak, Michigan. On the East Coast in North Carolina, it would be Robert Evans. And up in New York, it would be Robert Moldwin. And there are times when, listen, if it's been 5 years and you're not getting better and your doctor's not giving you any answers, seriously, if you're within an hour or two of one of these national experts, you deserve to see a national expert. I would do it. I would do it. Why the hell not? You deserve life. You deserve comfort. And if your local doctor isn't giving you treatments, is not helping you progress, if you're getting worse, don't just suffer at home. That's when you want to go see a national expert and see if they can figure it out. And I will tell you, these national experts are phenomenal at figuring stuff out and finding those hidden, mysterious reasons why a patient isn't responding to treatment. Regina says that she had to have a total hysterectomy and went on bioidentical hormones, and that they really helped her bladder a lot. I miss my estrogen. Let me tell you, I loved it. I just don't. Now that I know I can grow cancer, I'm not taking oral estrogen at all, and it shows. I had some questions that were emailed to me. Let me go to those. Let me grab these real quick. So Stacy sent the question, I wanted to ask some advice about interstitial cystitis. My doctor thinks I have it, but we have not been able to confirm or deny it. He currently says it's a bladder disorder, which could mean anything, I think. I wanted to ask what's the best thing to do about this, about work with this condition. Is it best to let your employer know you have a disability? I was curious if incontinence and IC. Okay, so she's got 3 fundamental questions here. So question number 1 is that they have not been able to confirm or deny. Okay, so So Stacy, if you're watching, you really need to think about subtypes. We have to focus first on what unique variation you might have, because that would help you and your doctor come up with a better, more accurate diagnosis for you. So if you missed the discussion on subtypes that I did here earlier, you can go onto our website and watch a video on that. So question number one is, we've got to figure out, is it bladder wall? Is it pelvic floor? Is it neurological? Is it central sensitization? And you can do that yourself pretty much. I mean, it's remarkable how easy it is to subtype yourself, unless you have hundreds of lesions. That's harder to subtype. I mean, for you to do. They have to look at your bladder to find them. Okay. What's the best thing to do about work when you've got something like this? Well, you know, you're not required to give your employer any personal health information under the law. And while it might seem natural to say, hey, I've got a bladder infection or something like that, sometimes less is more, because we do know that some employers are not ethical, and some employers are looking for reasons to get rid of people. And I've written blogs about it on our website. We have a whole section on disability and work. In fact, in my last magazine is an article, Keeping IC Patients at Work, where we give sample job accommodations that you can ask for that would make it. Here's the article, Keeping IC Patients at Work. So my natural inclination is to not tell them details, but just to say that you have a pelvic injury, something like that. They're not, I wish I could remember the exact law. It's just not coming to me right now, but you're not required to violate any of your privacy at all and to release details. As long as you've got a doctor note saying that something's going on and you might need this time off or this accommodation, that should be good enough for them. I don't know. I mean, I just kind of come from a position that less is more. You know, you may not know this, but I actually got laid off because of my IC. I was working for a nonprofit. I was their fund development director, and I was out on disability. I mean, my God, I was bawling my eyes out. We didn't know what it was. I had the equivalent of a chemical burn. That was my diagnosis, was chemical cystitis, and my employer could not have been more rude. My boss told me that I came from weak stock. You know, she said that in the hallway outside my office. You just must come from weak stock. Like, really? Are you kidding me? How dare you insult my family that way? And I'll tell you a funny story. So, this will give you a good story to share. So again, my first year, I had chemical cystitis. We didn't know it was IC. I didn't know about diet. I was drinking a quart of cranberry juice a day, not having a clue that the cranberry juice was killing me. You know, it's just making and aggravating the injury in my bladder so much more. You pour acid on a wound every day, it's going to get bigger. And believe me, mine got worse. So over the period of that year, I went from what was probably a moderate burn to a very severe, I can barely walk pain kind of burn just from that freaking cranberry juice. And so I had to go out on, I did take time off to go to UC San Francisco and get medical care. And she challenged me and she kept saying, you just want to work from home and you look healthy, you look well, all that sort of stuff. And there was nothing I could say to explain it to her because she had just left the nunnery. She just left the convent. This was her first job out of the convent, and she'd never been sick before, and she never had a bladder infection before. So I had been in the hospital, and I had my hospital band as proof that I was in the hospital because she was a real bitch. And I had gone into, so I was out on leave, gone back into the office to drop something off. She called me into her office and she just said, you know, Jill, you don't look sick. I don't believe you. I don't believe that you are sick, period. explain it to me. So I'm sitting there like grappling. It's like the world's worst bladder infection that will not go away. And she's like, well, I've never had a bladder infection. I don't know what that feels like. And then I'm like, here I am. I mean, like I'm really just trying to find a way to describe it, right? And I just go, it's like honeymoon cystitis. I forgot I was talking to an ex-nun. And she goes, well, what's that? And I said, well, sometimes that happens to women on their honeymoon when they become very irritated because of intimacy. And from that moment, I became the dirty sex girl in her mind. She believed that my IC was happening because I was having dirty sex. And I got laid off 4 weeks later. And then I sued for disability discrimination because they only terminated people on disability leave. There were 2 of us. And in her deposition, she admitted that she was parked on my street watching me with my boyfriend at the time, trying to approve that I was having dirty sex. And it's like, honey, seriously, when your bladder's screaming, you're not going to have sex. And I hadn't had sex in months. And she was trying to prove that I was the dirty sex girl. And she admitted that in deposition, which is why I eventually was able to settle my case for, something good. So that's my little story about work. So again, don't do what I did and compare IC to honeymoon cystitis. Holy smokes, that was a mistake on my part. Lynn says, my husband Peter has this for IC for more than 5 years. We need a second opinion, maybe at Stanford. John Muir Hospital is where he goes in urology. Daytime is good, but early morning he has urgency and goes every hour, so no sleep. So Lynn, rather than going to Stanford, I would head over to Vista Urology. You've got a husband and wife team who are national experts at pelvic pain. They teach the classes at AUA on pelvic pain. And so you've got Chris Payne, who specializes in female urology, and his wife, Dr. Jeanette Potts, specializes in male pelvic pain. And when you go to Vista Urology, you're basically working with both of them. And so that's where I would send you. I would send you perhaps to Vista Urology. And they would be able to tell if it's bladder wall, if it's pelvic floor. And I will tell you that Dr. Potts is a master at studying and analyzing the pelvic floor muscles in men to find injury, so much so that she's worked with professional athletes and football teams. So that's really where I would go. Lou is asking for a website address. Our website address is ic-network.com. Oh, and hey, we didn't do our freebie today. I always do freebies during chats. And so your freebie today, if you, as my gift for coming to our lecture, is you can have a free food card. This is our new IC diet card. I'm sorry, I can't get it to focus. And our medic alert card. This is for restroom access. So if you, and if you've already gotten these, then please don't ask for a second set. But if you haven't gotten these yet from us, if you can please send me your mailing address. Some of you reply with your email address. I cannot mail these to an email address. If you would like our freebies, I need you to send your mailing address to icnetwork@mac.com. And I would be more than happy to send them to you. I think that there's about 3 or 4 from our last meeting that I have not been able to send yet. But I will. But if you haven't gotten them and you already requested them, just go send me your address again. But if you already received them from me, then don't do it again. Okay? Well, how would I know? You can do it again. All right. Getting back to Stacy with her mailing question, she was curious if incontinence and interstitial cystitis go together, and the answer is usually not. But incontinence and pelvic floor dysfunction do go together. If you've got weak muscles, so again, we go back to this muscle model. So here's your pelvic floor, and it's nice, It's holding your bladder, it's holding your uterus and your rectum, and it's also supporting your urethra. If your muscles are weak, guess what? You become incontinent because it lets stuff through. And that's where you can also have a prolapse. And I have a little demo. Where is my, here it is. Okay. So there are two things that happen when your muscles get weak. One of the things that happens is they can get so weak that your bladder can start protruding through your vagina, or your uterus can protrude through your vagina. That is what we call a prolapse. And so anytime you've got a prolapse, you've got extremely weak muscles to the point that physical therapy might not be enough. Kegels, you're probably past the point of Kegels. And what they would do is either give you a pessary, or they would do a surgical suspension to try to get these muscles a little bit tighter to hold your organs in place. If you're just starting to leak a little bit, it's important to have that pelvic floor assessment, but at the same time, work with a physical therapist, learn how to do a proper Kegel exercise if that is what's going on. All right. Teresa asks, do other people suffer from inflammation in the vaginal area, as well as what feels like a temperature rise in urine and difficulty passing urine? Teresa, that's probably that can be a couple of things. So the temperature rise in your urine, so you feel like you have urine burn. Okay, your urine is not hotter at all. What it means is that the skin that your urine is crossing over as you're peeing it, aka your vulva, is vulnerable because of probably estrogen atrophy. So again, yes, this is a three-dimensional look at the bladder wall, but this is also a three-dimensional look at the vulva and the urethra. So you've got a layer of mucus, and you've got tissue, and you've got blood vessels. So you can have estrogen atrophy on your vulva. And that's usually one of the very first signs of perimenopause is that burning on your vulva as you're peeing, or burning in your urethra as you're peeing. So I would want to know what the quality and health of your skin is. If it's dry, then that means that we're in an estrogen atrophy position, which could explain why your vagina is tender, your vulva is tender, your urethra is tender, and your bladder is tender, what we know as the genitourinary syndrome of menopause. The difficulty passing urine is a different story. That is probably tight muscles. Probably tight muscles. I am people send in questions too, so I'm reading those. The last time I saw my urologist, he told me that I have Hunner's lesions, but I have no pain, from which everything I read comes with quite a lot of pain. I have flare-ups, nothing too unmanageable. You could take Desert Harvest Aloe daily. Can you tell me if it's unusual to not have pain? I would really question that you have lesions. I mean, seriously, lesions scream. They hurt. So the fact that you have absolutely no pain is very odd and unusual for me. I don't think I've ever talked with a patient with active lesions who was not struggling with pain. So, again, I have to wonder, are you another subtype? I mean, maybe when they looked at your bladder, your bladder started bleeding from the hydrodistension, giving you a false positive of a Hunner's lesion. But maybe, in fact, you actually might have pelvic floor issues instead. That could be driving your symptoms. That would be the equivalent of a false positive. It wouldn't surprise me at all. I think we see that a lot. All right. Diane online says, do I know if Cystostat will be available in the USA in the near future? The answer is no. So guys, one of the things that's happening in Europe and Canada is that they are stopping making some of the typical bladder installations, including Rimso, DMSO, and Cystostat. I don't know the status of Uracyst. The company that owns them right now is Mylan Pharmaceuticals, and they have stopped producing them with no explanation, no transition, no announcement, nothing to educate patients about it. However, there is still a treatment that you can look at rather than taking Cystastat individually, or Cystastat is sodium hyaluronate as a solution put into the bladder. Uracyst is chondroitin sulfate as a solution put into the bladder. So the individual manufacturers have apparently stopped, although I'm not quite sure about Uracyst, but I know that's true with Cystastat and Rimso. However, there is a treatment called Ialuril, Ialuril, available in Europe and Canada that is a combined chondroitin hyaluronate installation. So if you are somebody who is relying on Cystastat or Uracyst and they're no longer available, why don't you see if Ialuril is available? It's really quite interesting because Cystastat was around 25 years ago as a bladder installation. And then Uracyst came along a couple of years later, the chondroitin. And the two companies fought like beasts. They fought like beasts. Research study after research study, trying to outprove each other for market share, right? And neither one of them on their own were particularly successful, which is why they were not approved in the United States. However, they certainly did help some people. But then finally, some doctor put them together. And when you put them together, they actually perform really, really well. And that is called Ialuril. So don't assume that this is going to be worse. It's probably going to be better than Cystastat on its own. All right, let me see if I have any other mailed in questions. KP asks, are live sessions recorded and available? Yes, the live sessions are available on YouTube and on Facebook, despite the first 5-minute chaos that you often see in them as I'm setting things up. All right, let's go back to questions. Let's check YouTube here. Vonda, does salt increase IC pain? Yes. It's one of the earliest forms of torture, rubbing salt into an open wound. If you've got a bladder wall injury, if you rub salt into it, it's going to hurt. So we definitely want you to back off on salt. We don't want you to have things like pretzels with rock salt on them. That would be a real big mistake. However, a little bit of salt to taste on food is usually fine. Isabella says, can an MRI show Hunter's lesions? I don't think so, hun. I don't think so. Dale says she had an appointment with Dr. Evans in North Carolina in December. You're going to love him. Excellent hands. Dr. Evans is the undisputed top doctor in the United States for IC, according to patients, which is why he's always voted the top doctor. Patients normally love him. 99% of patients who see Dr. Evans absolutely love him. And we have patients who fly from California to North Carolina to be seen by him. LaWayne asked, do I recommend using estrogen cream for everyone with IC? No, definitely not. Definitely not. It's all about the quality and health of skin. It's all about the quality and health of your skin. If your vulva is dry, and if your vagina is dry, then so is your urethra and so is your bladder. And that is when we turn to using a topical estrogen cream, as long as there is not another outstanding risk. I, for example, because they caught my cancer very, very, very early, like literally, it was like the cells were just starting to create a foundation for a tumor. So it was not active cancer. It was like the step right before is complex endometrial hyperplasia with atypia and a vague architectural complex. That was my diagnosis. So in that case, my doctor felt that it was okay for me to use a little bit of vaginal estrogen, which is what I do. Not taking it orally. It was the oral estrogen that produced an abundance of estrogen that caused the polyps in my uterus. But it's a personal discussion, and there are pros and cons, and you just have to be informed. I do it because I usually rub it not in my vagina, but at the entrance to my urethra, about a pea-sized drop, because if I don't do that, my urethra really stings. It really helps me. But I'm not over the top with it at all. I'm very careful. I don't go over the top. I just use it small amounts as needed, which is what somebody with central sensitization would do anyway. Okay, coming back to Facebook for your questions here. Where can you buy books on IC, and what are the best books? I have all the subtypes. Well, Carol, as a matter of fact, you can buy those books right from the IC network. That's how we pay for these meetings, is we get to sell stuff. So you can buy all of these at icnsales.com, including a membership to the IC network. But I happen to have the best books right here as a demo. So let me just show them to you. There we go. These are, okay, so these are right now the de facto best books on IC and pelvic pain. Although I will tell you, we have a new book that should be coming out soon that is also going to join this. So for IC specifically, the book you want is The Interstitial Cystitis Solution by Nicole Kozian. So she's a physical therapist in Southern California at a clinic called Pelvic Sanity. And it's an excellent book. You can read my review about it on Amazon and in our magazine. One of the things that I love about this book is it's really the first one to explain the intricate relationship between the bladder and the pelvic floor. Up to this point, patients didn't really understand that the pelvic floor could cause bladder symptoms. This book explains it to you. So this would be book number 1. But if you also have pelvic floor dysfunction to any great degree, or any funky muscle issues like I do, and SI joint dysfunction on my and piriformis dysfunction on my left side, these are the books that I suggest. Ending Female Pain by Isa Herrera, or Ending Male Pelvic Pain by Isa Herrera. These are just a veritable Bible of what you can do to work with muscles. One of the things that we've known from way back is whenever you're in a pelvic floor flare, one of the things you can do is squat down, go into the prayer squat. You can see you're doing that right there. When you squat down like that, that forces your muscles back into their proper location and their proper length. And so if you're starting to feel your muscles get tight and you're at the bank, drop your car keys, squat down, and just sit there for a couple of seconds. And that might prevent your pelvic floor from starting to spasm. So you can see lots of good exercises and suggestions in here. But I will tell you that 5 minutes reading this book will teach you more about how your body works down there than years and years of working with doctors. It's absolutely stunning. You can see all my red marks in it. It taught me so much. As an example, she talks about the layers of your pelvic floor muscles. You've got, remember, so here's your pelvic floor. You've got shallow muscles by your urethra. You've got mid-level muscles, and you've got deep muscles. And so when they do your pelvic floor assessment and they stick their finger in your vagina or your rectum, they're going to test shallow muscles first, and then mid-sized muscles and deeper muscles. And she actually has diagrams in here so that you can see which muscle groups are at which level. So that's the third layer that they check. And then the first layer and the second layer. Okay, so Ending Female Pelvic Pain, Ending Male Pelvic Pain are the books I recommend for anybody struggling with severe pelvic floor dysfunction, and or Heal Pelvic Pain by Amy Stein. Both authors are physical therapists in New York. This book is also for men and or women struggling with pelvic floor dysfunction. And Amy also has a wonderful DVD that we sell called Healing Pelvic and Abdominal Pain. So if you would prefer not to read a book, but to actually watch a DVD, that would work. So again, lots of exercises in here on how to relax your pelvic floor, featuring both men and women. This is such a good exercise right here. You know, kind of one of the tests to see how tight you are is to lay on your back with your knees up and then just flop your knees over. Just flop your knees over, you know, like you're going to have sex. Just open them up and flop them over and see if you can do it easy or not. If it's tight, then that tells us that you got some pretty tight muscles going on. And then last but not least, the newest book that we have, I'm going to rave about. This one has just come out. It's called When It Hurts Down There. It's written by Dr. Angie Storr, who is an OBGYN in Texas. We're going to be selling it soon. I read it a week ago and did a whole lecture on it last weekend. I love this book. I love this book because it talks about pelvic pain and all the conditions related to pelvic pain in a woman. IC, irritable bowel, vulvodynia, endometriosis, and pelvic floor dysfunction. And she talks about the biome. It's 15 proven techniques to alleviate pelvic pain. It is solid. It is great. As an example, let me give you an example here. So, one of the things that we consistently see in young patients is tight pelvic floor muscles, especially dancers. And I remember when I was referred to UC San Francisco for my care, he was treating ballerinas from the San Francisco Ballet Company with quote unquote IC. And we know in hindsight now that they really probably didn't have IC, they had pelvic floor injuries. And when you're standing normally, your weight is centered properly around your hips, around your hips and the structures, bony structures of your hips. But if you're taught to do a pelvic thrust, God, I'm sorry, that's a terrible picture. So here's a normal way of standing. But think about how a ballerina is taught to tuck under, right? I don't know if my shirt, you can see that. You tuck under and then you walk tucked under. I know that because I did ballet for a couple of years early on. And when you tuck your pelvis under, you're forcing your pelvic floor to carry your body weight. And that's hard on the pelvic floor. You're putting much more stress and pressure on your pelvic floor muscles. And so, man, this is just really an outstanding book. But the best thing about this book, by far, is her discussion of pain processing. How many of us have been completely offended when somebody says, hey, man, you need to go into therapy for your IC? And we're like, what the hell are you talking about? IC is not in my head. IC is in my bladder. Don't give me that. Or they say, go meditate or go do this or do that. And, it's a normal and natural process to be completely offended when somebody says that. But she's the first one to explain why those might help, because she talks about pain processing. So think about it. If you got pain in your finger, okay, the pain goes from your finger up through your arm, it hits your spinal cord. At the top of your spinal cord, it goes to your lower brain, it goes to your midbrain, it goes to your upper brain. And it's your upper brain that tells you to move your freaking hand off of the stove, right? It's instantaneous. Nerves flash up and flash back. So the question is there any way that we can disrupt that nerve signal? And she says, yes, there is. One of the first, but it's based upon where you're going to catch it. So like if you take an opiate medication for your bladder, opiates work at the spinal cord. They will stop pain sensation at the spinal cord. That's why opiates are better than Advil at breaking organ pain. But you've got 3 other targets where you can stop or reduce that pain sensation. The first one is the lower brain. The lower brain it's the gateway. We call it spinal gate theory. So your body is wired with tens of thousands of nerves. And if your brain was listening to them all at one time, you would be crazy. There is a mechanism called the spinal gate theory that blocks almost all of those nerves and only sends the most important pain message up for action. So there was a doctor who was studying pain, and he was in India, and he was going to leprosy clinics. Leprosy is very, very painful because it's an infection that eats away at bones and stuff like that. One of the things that he noticed is that outside the clinic, as patients were waiting, they were doing this. Lots of patients were just out slapping their inner thigh. And he was like, and not only just slapping their inner thigh, they were using wire brushes on their inner thigh. And he was like, why is everybody doing that? I have no idea why. Why are people slapping their thigh? And he talked to a doctor in there. And the doctor explained that it's a distraction mechanism. That when you slap your thigh, your lower brain thinks that that's the most important pain message to go through. And so it will halt other pain messages. So think about it this way. If you step on a nail, if you stepped on a nail yesterday, you know you'd be screaming bloody murder and probably at the emergency room getting a tetanus shot, right? But now it's 24 hours later, your foot still hurts quite a bit because it's a deep puncture wound. But let's say you fall and you break your hand. Are you going to feel the nail in your foot? No, you're not. You're going to feel the broken hand. That's spinal gate in action. And so the first thing that she talks about in here is distraction. Okay, you can distract yourself from the pain. And I used to do this. I used to do this when I was driving because driving used to hurt a lot. So I'd be driving, slapping, or I'd put a TENS unit on and I'd put there, and that would be another form of distraction. I even flew to Europe with a TENS unit on in the plane doing that. And it works. Try it right now. Slap your leg right now. And ask yourself, okay, do I still quite feel my bladder pain? Not as much, probably not as much. The second place that you can affect your brain's ability to process pain is at the midbrain. Now, the midbrain is interesting because it's the part of the brain that controls context. So it's a part of the brain that tells you, is this good pain or bad pain? So as an example, you can have pain. Let's see. What's the example? I want to give you a good example. It is the part of your body that tells you if this pain is happy pain or bad pain. So if you're on a roller coaster and you're flying and you're rubbing against the side and it's hurting your arm, that's good pain. So that's pain that your midbrain doesn't need to send to your upper brain for action. However, if you have pain because you've fallen and broken something, that is bad pain. That bad pain is immediately going to be sent up to the upper brain. So how can we distract pain at the midbrain level? Well, that's where a lot of thinking happens. And she explains it. The way the brain works is it draws other nerves, right? I mean, it's a physiological process. Nerves are working. Nerves here and here and here and here are all working together and responding to this pain. So how do we break that pain? Is we distract those nerves with other things. And that's where something like, she talks about it in here. Hold on a sec. Oh, here's something else that's really funny. Her first suggestion is, if you're in pain, curse. Use foul language when pain is really intense. If you've ever hit your thumb with a hammer or stubbed your toe on a table, you've probably sworn or at least wanted to. This kind of reactive vocalization starts in the lower brain gateway. It's a spontaneous reaction to pain, and it actually reduces the pain signal. So you have permission to curse, you know, as long as you're comfortable with that. I don't know about you, but I've cursed a lot the last couple of years. Hopefully we will stop cursing after Tuesday. Pressing fingers. That's all I'm going to say. The way to interfere with pain in the emotional processing area is to have more happy emotions and less unhappy ones. Pain is processed faster when it's linked to an unhappy emotion like fear, guilt, anger, disgust, hatred, or rejection. The brain assumes that if you're unhappy, the pain signals are more important. Therefore, the brain is going to send those pain messages on. However, pain is processed more slowly when it's linked to positive emotions. And so this is where the power of positive thinking really helps, because it slows down the pain message. So things like trying to look at the good side of things rather than just the bad side of things, or she calls it savoring a good book, a pleasant smell, or a hug with your kids is the absolute best. It's really strong positive emotions. Enjoying a tasty muffin at work, or the way your husband kisses you. Pay attention and savor the feelings, because what you're doing is you're involving those nerves in something good. So anyway, I'm telling you, my friends, after reading this, I really understand why the power of positive thinking works. I was thinking about this yesterday when I was driving around in the car. You know, when I was in my 20s, I was really depressed. I was trying to figure out why I had IBS and vulvodynia and all these other things, and I wasn't happy, and I was in pain, and I was suffering a lot. And when I finally, one of the real big things that turned me around was when somebody they gave me several books, but one of the books was The Power of Positive Thinking. And if you could see my office right now, like, it is filled with happy things. My day is dominated by happy things. I don't dwell on this stuff anymore. And I think now I understand why that helped me so much. So anyway, again, I would and for this book, if you go to whenithurts.com, you can order it for $19.99 directly from her. Don't order it on Amazon. It's like $34. So get it here, whenithurts.com. Get it. I think it's really good. All right, back to your questions. Denise says, is Elmiron good for us 3 times a day? Elmiron can be used 2 times a day or 3 times a day. Some patients will take Elmiron 100 milligram pill 3 times a day. Others will take 400, 2 in the morning, 2 in the evening. One of the challenges with Elmiron, I often say, is take it on an empty stomach. It is very hard to take it on an empty stomach, and it is known for causing stomach distress. And so you can take it with a snack, and that's okay. And the guy who invented Elmiron said that that's okay. But again, with Elmiron now, we have some pretty strong evidence that Elmiron can lead to eye disease and eye damage. And so you want to definitely look at other bladder coatings first and follow the AUA treatment guidelines. The American Urology Association and their 6-step treatment protocol for IC suggests doing supplements first because they contain less risk of adverse event. And so the supplements that patients have turned to instead of Elmiron, or before considering Elmiron, are going to be something like Cystoprotect, Cystorenew, or Desert Harvest Aloe. Okay, so the other challenge with Elmiron, unfortunately, is it is becoming incredibly expensive. It can cost thousands of dollars now, $1,500, $1,800 for a prescription, whereas these are literally under $40 a month or under $50 a month. So many people have had to stop Elmiron simply because it's just gotten too expensive. Laura says she got her microgen results. It shows E. coli, Enterococcus facialis, and Provatellia bivia. The Enterococcus facialis, I believe, is a beneficial bacteria. The E. coli is pathological, and I'm not sure about the Provatellia. You'll have to Google it. Well, let's take a look. Let me see if I can find it for you. I'll go to my super secret. It's a gram-negative bacteria. Hold on, is Provatellia, what was it? Provatellia bivia. Let me go to the National Library of Medicine. And let's see what they have to say. Provotella. Yeah. Spell that right? No, Prevo. Hold on. Well, I mean, it's definitely, it looks like it's affiliated with biofilms. And it's part of potentially a bacteria in bacterial vaginosis. Fascinating. It's also implicated in gut vaginal dysbiosis. You know what? Hey, Laura, call me on Monday, or call me tomorrow or the next day, and let's dive into the research. And maybe I can, maybe we can find some good, useful information for you that way. Okay. Hi, Sherry. It's nice to see you too. Melissa, I have an InterStim device. 2 weekends in a row, I was in cold weather, and the implant hurt so bad. About an hour later, I started a horrible flare. In bed with one now. I know it sounds crazy, but could the device getting cold? Girl, I got to tell you, InterStim is associated with hundreds and hundreds and hundreds of very severe adverse events. Whenever you're exposed to cold weather, things, your body naturally draws in. Your blood flow is diverted from your hands and your limbs over into your body to kind of protect your major organs. Muscles are known for getting tighter in cold weather, again, as a way of protecting yourself. So I would have to wonder, I mean, what you have to do is, we really have to focus on where is your pain? Is your pain at the generator device, or is your pain down where the electrodes are in your lower, by your lower spine and in your sacrum? You need to tell your doctor about this. Again, if you call me, I can tell you where you can research this. It's the MAUDE database from the FDA, where you can read adverse events. But anytime a device is giving you pain and making you worse, we have to look at the device and make sure it's functioning correctly. And to me, that's an important phone call to your doctor, to let them know you're having a problem and that this has happened. And they can then call the manufacturer and see if the manufacturer has any well-known or known issues that would explain why this is happening to you. Okay. You know, metal gets cold. So I guess the other thing I would really want to know is the generator right underneath your skin? Was it exposed to cold, and could that have affected it in some way? I don't know. It's a good question. Tracy says she has IC subtype 2, was tested for Lyme disease. They found the antibody, but not enough to be determined to be Lyme. I'm wondering if you should get a second opinion. I guess what I would do is do some research, see if you're showing any other signs of active Lyme infection. I mean, if you catch a Lyme infection early, you can heal it. So it may be that you actually had an early Lyme infection that was treated and is dead, and you just have antibodies showing that at one point in time you were exposed to it. So I think the question is trying to determine if you have any active Lyme, any active other Lyme symptoms, and I would do some research and read about that. Sandra says, have you heard that prednisone or other steroids aggravate IC? I will tell you that long-term steroids are certainly not recommended for IC, and they are specifically mentioned in the AUA guidelines. I have it right here. Treatments no longer recommended by the American Urology Association as long-term steroids. It would be very interesting to go over to the AUA guidelines. which you can do that over here, auanet.org. auanet.org. In the upper right-hand corner is the link that says guidelines. Click on that. Go to the guideline page. Click to interstitial cystitis. Go to the IC guidelines and read what they say about the research related to long-term steroids. They are no longer recommended. Christy says, let's see. Jacqueline says, can naturopathic or homeopathic remedies help with IC? Well, so Jacqueline, the real question is, can naturopathic or homeopathic remedies help with various subtypes of IC? Would homeopathy work for Hunner's lesions? Probably not. Would homeopathy work for some variants of bladder wall-driven? I don't know. Would they help with pelvic floor? Definitely not. Would they help with a pudendal nerve entrapment? No. Would they help with central sensitization? No. We've never looked at homeopathy as being particularly helpful for IC, and I'm not aware of any research studies that have. You know, one of the problems is we often go to naturopaths or other doctors that are kind of specializing in alternative holistic approaches, and they can do all sorts of different testing to kind of justify different treatments. The proof is in the research. Do they have any research that actually proves that what they're doing helps a specific subtype? You can't just put every IC patient down into a single barrel anymore. You just can't, okay? Melissa, she had a urethral diverticulum. Cool. Lynn asked if we could participate in a walk for IC in the Bay Area. Lynn, if you'd like to put it together, let's do it. Let's do it. Erin had a flu shot, and a week later she had a flare. What do I think about natural doctors for IC? I think that there are some very good natural doctors for IC. The one that comes to mind is Dr. Gio Espinosa, who runs the Integrative Urology Department at New York University in New York City. You know, they just have to be, they ideally are an MD. They've gone to medical school. They understand the physiology underneath the variants of pelvic pain. You just remember, we can't put everybody in the same bucket anymore. There are very distinct variations. So, and I completely support a natural approach to life and a natural approach to therapy. Let's try, if at all possible, to do things that carry less risk and have less risk of adverse event and don't expose us to potentially toxic chemicals. Diet modification, eating organic food, trying the supplements, things like that, physical therapy for pelvic floor stuff, relaxation, things that will interrupt pain sensations as they go up the brain. I'm all for that 100%, and that is in fact the way that I live. Okay, and that's really what the AUA supports too in their 6 steps. They leave the really aggressive stuff for later. They want you to do the easy, more natural stuff first. Cynthia, she had a hydro on Friday. I'm in a lot of pain. I'm just getting tired. Well, listen, yeah, you just had your bladder stretched. It should be getting better though. If it's been 2 days, you should be feeling better. If you're getting worse, then you probably picked up a post-op bladder infection, which is very common after hydrodistensions. So if you're peeing blood, if you've got a fever, or if your pain is getting worse, that usually means that you picked up a nosocomial infection from the medical instruments. So call your doctor tomorrow and tell them that you're worse and ask them, tell them that you think you might have picked up an infection, and they should have given you an antibiotic at the hospital, either a shot or a pill, but they happen. Lynn, the name of as asking for the Stanford doctor, that's Phil Hanno, Philip Hanno, Hanno. Stacy had a bladder distension a week ago, still having bladder spasms. Holy crap, guys. 100 new comments. I'm behind. I'm going to try to scan through these really quick. The salt increased IC pain? Yes. April, was that icnetwork@mac.com? Yes, it was. icnetwork@mac.com. Tracy says, ooh, great question. If you have scoliosis and are naturally off balance, would pelvic floor exercises help? I had a spinal fusion in 96 and I've had bladder issues for that long as well, but just this year diagnosed with IC and pain. Tracy, I also have scoliosis. I have an S-curve. I should be at least an inch and a half taller. I'm 5'9". I should be basically 5'11". And so my curve is an S, and it's a balance curve. But what they say is that, yes, my left side is slightly higher than my right side, and my left side is where I have my muscle problems. Number one, there is a new yoga program that they have found that has helped scoliosis tremendously because it allows you to target muscles on the outer curve or the inner curve of it. But you've had a spinal fusion, that might be a little bit more issue, a bit of a challenge. Boy, if I were you, I would really go to a seasoned physical therapist and explain to them you've got scoliosis, you've had the spinal fusion, but you're wondering if your pelvic floor muscles are compensating, and they may be able to give you a tip. So in my case, I have had left side glute pain for years. Piriformis pain, years, and it's gotten worse over years. And I've had, the doctors have been all over the place, and I've had nerve blocks, and I've had steroid injection, you name it, I've had it trying to fix this thing. And their consensus was that it was off balance because of the scoliosis. However, I did just go to a brand new physical therapist because I refused to give up. And this new physical therapist has worked with professional athletes. And what he found was that my left glute was simply not engaging. My right glute was working. My left glute, the muscle itself, was not working. And as he was watching me walk down the hallway, he could see that I was going from the right end. Nobody else, no other doctor had ever seen that before. And so now what he's doing is he's giving me exercises to activate the left side again correctly, because we can activate it. It just isn't turning itself on naturally. It's been the right side's been compensating for years, so the left side is not proactive and active the way it should be. So again, I would really pursue that. Holy crap, 100 comments. Wow. Lark is asking, are you aware of any information or experience with L-carnitine being a bladder irritant? No, I don't believe it is a bladder irritant. It's kind of in the L-arginine family. It's better than L-arginine. I wouldn't expect it to be a bladder irritant at all. And hold on a sec. Lark, who is in here, won second place in our IC Awareness Month poster contest. Congratulations, Lark. Thank you so much for your entry. That was wonderful. Stacy said, for some reason, it never dawned on me to become an IC Network member after all the advice and help in these videos. And the website has given me, it felt good to give back. Thank you. Thank you. We really need the members to keep us going, guys. Ravonda is using VMagic, but she got a yeast infection after about a week of using it, wondering if the honey in it could cause the yeast infection. I wouldn't, possibly, because candida feed on sugar. And so I have to wonder if you already had an existing candida infection and you just gave it food, and that's why it overgrew. I've been using VMagic consistently for a year now, and I've never had a yeast infection from it. I would bet that you probably already had one, and it's the equivalent of if you have a systemic yeast infection and you eat ice cream, the ice cream feeds the yeast and the yeast flourish. So the honey might be feeding the candida, yes. Can somebody please put up the name of the last book that she said was the best? When It Hurts Down There. When It Hurts Down There. Thank you. What do I think of stem cell therapy for IC pain? That's from Lynn. Lynn, it was Dr. Elliot Lander at the California Stem Cell Research Center in Southern California that was the first to really study stem cell therapy for IC. And what he found was that, so what they did is they did, I'm forgetting the exact name of it. Basically, they took stem cells from your fat. They did a little liposome procedure, and then they processed your stem cells off of the fat and created something called stromal vascular faction, which is a mixture of stem cells and growth factors, and then they would give it back to the patient. And what they found was that it was helpful, but it was not durable. It was not durable. It did not last long for any great period of time, and so patients would have to go back for 6 months. And then the FDA got involved and issued a warning about companies promoting stem cell therapy for various diseases, and there's been a bit of a smackdown on the stem cell community. The ultimate barrier with stem cell therapy is that it is very, very expensive. You're talking $8,000 to $10,000 to do it, and it might only last for a couple of months. So in that case, again, Lynn, I would come back and focus first on your subtype. I want to know what subtype you have first. Stem cell therapy would not help for IC subtype 3, pelvic floor, IC subtype 4, pudendal neuralgia, or IC subtype 5, central sensitization. I don't know if they have any evidence that it might help with lesions or bladder wall. Lark, the website address is whenithurts.com. Whenithurts.com. Let's see if they have it here. I know I've got it written down somewhere. Well, okay, I can't find my slide. So it's just whenithurts.com. Alrighty? All right. Hey, guys, and for people who just come in, let me introduce myself. My name is Jill Osborne. I'm the president and founder of the Interstitial Cystitis Network. This is one of our live IC support group meetings. We are now doing meetings twice a month on the first and third Sunday, scheduled at 12:30 Pacific time. They are simulcast through Facebook and YouTube. However, I may be switching to twitch.com, so Twitch TV, so that I can do more stuff, show you more stuff rather than you just looking at my face talking, which I know gets boring after a while. We also do drop-in meetings randomly throughout the week, usually on a Wednesday. I will either do them early in the morning or I will do them late at night because I'm going for different time zones. So if I do it late at night, I'm gonna hit Asia a little bit more effectively. So I have been known to do meetings at midnight Pacific time. So the actual scheduled ones are the first and third Sunday. And then if you just sign up, like our Facebook page, or sign up on YouTube, you'll get an automatic notice when we go live. Alrighty? Letitia asks, when getting your part, Letitia, I'm not sure I understand your question. When you're getting your bladder scraped to remove cancer, can that cause IC symptoms? Well, it's hurting your bladder, hon. I mean, when it's not quote unquote IC symptoms. It's seriously just bladder injury. So, and this is, again, it's a perfect example. So whenever you sustain an injury of any type, what that means is that you've lost an area of protective coating and skin. So anything in your urine can penetrate more deeply into the bladder wall and trigger bladder wall pain. And so whether it's from menopause, whether it's from chemotherapy, or whether it's from a bladder cancer therapy, when urine is allowed access deeper into the bladder wall, you're certainly going to get frequency, urgency, pressure, pain. You know, the bladder only knows one language: frequency, urgency, pressure, pain. Everything feels like infection because those are the symptoms you associate with infection, but those are actually the symptoms that you most associate with bladder wall injury. Letitia, the good news about bladder cancer is that it is one of the most easily treated cancer because they can just scoop it right off of the bladder wall. They generally treat it with BCG, which used to be a treatment for IC, and you can get through it and just know that healing happens, and bladder cancer is considered very, very treatable and curable as long as you catch it as early as possible. The number one cause of bladder cancer is cigarette smoking, exposure to chemicals. And again, this is why when you smoke, all those toxins go from the smoke into your lungs, into your bloodstream, where they are then excreted through your kidneys. So they collect in your kidneys and then are put into your urine. And so if you're a smoker, you've got all these carcinogens floating around in your urine. And if you happen to have an injury to your bladder, those carcinogens are going right deep into your bladder wall where they can trigger cancer. We also have research that shows that children exposed to secondhand smoke in their home have symptoms associated with bladder wall irritation and IC. And that is a secondary effect of smoking on younger bladders. So if you're exposed to smoke, or if you're a smoker, please stop or get away from the smoke. If you've got a smoker in your family, you need to ask them to smoke outside so that you're not exposed to it so much. I'm coming down to YouTube now. Lisa asks, how long do you think it could take estrogen cream to help my IC symptoms? Well, I help IC symptoms. I will tell you for my urethra, it took a week. That's all. It took a week before my urethra calmed down massively when I started using an estrogen cream. Lisa says, does it make sense to take both Sister Protect and Sister Renew? No. Just do one at a time. And because we got to know what's working and what's not working. I mean, hey, we IC patients, we are uber sensitive. So we don't want to throw more in, because then we won't know what's bothering you. So start with Sister Protect. Start with one of them, whichever one you want, and see how you feel. And if your body likes it, work up slowly. You know, we always say, start with one pill, see if your body likes it, then do one a day for a week, see if your body likes it, then go up to 2 a day for a week, and go up to 3 a day a week. And if you can work your way up, that's great. And if you're not having side effects, that's great. I, for one, whenever I went over 1, I got loose bowel, and I do not like having loose bowel. So I'm one of those patients to take 1 a day, and it works for me. It feels like warm cotton candy in my bladder, and I like it. So if I'm flaring, I will take 1 Sister Protect or 1 Sister Renew. But again, we're all different. So I'm super sensitive. So thank you, Letitia. You have a blessed day too. Fred says, if Rome falls, we all fall. Thank you, Fred. We are, I think in our context, what we want to say is, if the pelvic floor fails, then the entire pelvis can fail. We must defend the pelvic floor, my brothers and sisters. Beauty says she has a blood clotting disorder, so cannot take any hormones. So if you can't take hormones, hon, and you're dry, then you want to use something like V-Magic. Let me get it and I'll show it to you. Hold on. It's just right outside the door here. I love this stuff. V-Magic. V-Magic. It is an organic olive, avocado, sea buckthorn oil that is as close to it's kind of like a very light Vaseline. It's super, super light, and it really mimics that protective coating on your vulva. And so if you're struggling with estrogen atrophy and dryness, you can try V-Magic. I'm super sensitive, man. I do not like putting anything on my skin. But I was desperate because I have estrogen atrophy from my hysterectomy. And this stuff is gold. You can buy it on the IC Network website, Medicine Mama's V-Magic Intimate Skin Balm. I even been putting it on my shoulder, a little bit on my shoulders, because I get this weird skin thing on my shoulders sometimes. Beauty says, my doctor hasn't tried installations, but he's already referring me to UCLA because he says my case is complicated. Well, what's good about that is he's admitting he doesn't have the skills to care for you. And so better to know that now than to waste a year or two doing stuff that just isn't effective. At UCLA is not really known as a major IC research center. Although we've had some Hollywood actors with IC who have been treated at UCLA. There is a female urologist at UCLA who has done IC research. Her name is Larissa Rodriguez. So it would be interesting to see who he would be referring you to. Lisa, is V-Magic for vulvodynia? Yes. V-Magic can work for a dry, irritated, sensitive vulva. Does V-Magic have an odor? Not really. Gosh, you know, it's like a really, 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 really light olive oil. But there's nothing bitter, or there's no perfume or scent or anything. I mean, it's fine. If you're smell sensitive, you shouldn't have any problems with this. I mean, I am wicked smell sensitive. I could stick my nose in there and it's not going to hurt me at all. Hello, Christine. Hi, Dina. Very, very nice to see you. I want to just last call for questions. We've been doing this for almost 2.5 hours. I've still got some juice in me, though. I'm willing to take more questions. However, I do want to mention 2 things. If you find these meetings helpful, would you please become an IC member so that you can get this fabulous magazine, The IC Optimist. We've been doing this magazine. This is our 15th year of doing the IC Optimist magazine. It is read by patients and providers around the world. You can get it for as little as $25 a year by email. What I will tell you is it is memberships to our magazine that really make these meetings happen and our website happen. This is how we support ourselves, is we have a store and we have a magazine because we are a medical publishing company run by IC patients. The content in our magazine is not released, much of the core stuff is not released publicly for at least 6 months. We give our members early insight into some of the big stories that are coming. This is our summer magazine. As you can see, we provide an extensive interview with the CEO of Microgen about next generation DNA sequencing. We have an article on possible job accommodations. But the most important article in this one is Inside AUA 2018, where we review in its entirety the class that was taught on IC 5 months ago to urologists around the world. It was a class taught by Robert Evans and Robert Moldwin and Jennifer Fariello. We have slides from the class. And so if you want to see how doctors are taught about IC, you can read it in our magazine. So please think about becoming a member of the IC Network. You can do that at icnsales.com. It will give you, you will have a member page, and it will give you instant access to past issues. There's 3 different memberships. Just read about it. Okay, go to icnsales.com. All right. I always end these, again, last call for questions. Last call for questions. I always end these meetings with a very, very important thing. The single most important thing I want you to remember from this meeting today is IC is not your fault. You have done absolutely nothing wrong. There is no shame. There is no blame. I don't want you to carry any guilt on your shoulders because you are struggling with IC like I did. I spent years thinking it was my fault. And I'll tell you, that was one of the reasons why I got so very, very depressed in my 20s. And ultimately, in the end, it is injury. And for most of us, it is injury. It is traumatic injury in some way. Injury to the pelvic floor, injury to the bladder, or you might have Hunter's lesions or whatever. But what you don't have, you did not cause this. This is not your fault. I don't want you to carry any shame or any blame. But I also really need you to keep IC below the waist. IC does not change your brain. It does not change your heart. It does not change your soul. It does not change your ability to love your partner. It does not change your ability to be a mother. It does not change your ability to be a daughter. It does not change your ability to be a son or a father or a friend. It is an injury. You're no different than someone who is hit by a car. So I want you to don't give up. Don't fall into that negative self-talk that we are so good at, of starting to think that we're damaged goods. Listen, if a family member was hit by a car, you'd be there 100%. Man, if they were laying on the couch with their leg up, you'd be changing the channel for them. You'd be getting them whatever they have because you love them. You deserve exactly that same love from your family, and I hope that you will ask for it. But what I really need you to do is every single day, I need you to do 3 small things. You know, it's really easy to get overwhelmed, think you got to do something big to get better. And I believe in laying a foundation through small events every day. So I need you to do 3 things for 15 minutes each day. The first thing I need you to do is I need you to do something that gives you comfort for your soul or your spirit. Nurture yourself in some way, whether it is going and walking in a park, or as I like to say, hugging a redwood, because I've never been closer to God than I have walking through a redwood forest here in California, or going to church, or listening to Joel Osteen, or reading poetry, whatever. Do something that gives you comfort spiritually. Then I need you to do one thing for your bladder or your pelvic pain for 15 minutes, whether it is making some food that you know is going to be good, or whether it's taking a hot shower or walking around the block. Do something for your health. Do something that we know is good for your bladder and good for your pelvis. If you struggle with anxiety disorder, for example, and you're afraid to leave the house, please open your front door and walk out to the street. And let the sun give you some comfort and some healing. Do little things every day to expand your world, okay, and to give you comfort. Following the diet, meditating, taking a bath, taking a walk, something good for your body. Or as I do every day, because I think about Starbucks every day because I love lattes, and this is my Starbucks for you this year. I will tell you, every single day in the morning when I think about doing IC Network work, I want that freaking latte right here. And I have to stop myself. I mean, I will even get in the car and start driving there when I will stop myself and turn around, because I know that's not good for my bladder, right? So sometimes doing good is just saying no to something. And then last but not least, I need you to build your noggin here, man. I need you to work on your knowledge for IC. I need you to read 1 article a day about IC. And I don't mean a Facebook article. I don't mean going into a Facebook group and reading what people are writing. That's really harmful for many patients because it's discouraging. You know, you have to remember that support groups are always going to be biased towards patients who are suffering. Whether it's a support group on Facebook or a support group on the IC Network or this meeting, or a support group that you go to in person. The people who come to these are people who are struggling. But you got to keep it in perspective, because for every patient online having a bad day, there are thousands having a great day. There are thousands having a great day. You've absolutely got to remember that. And so, you know, coming online and reading is not reading Facebook and stuff. That is not going to build your knowledge. Instead of perhaps coming over to the IC Network and reading the latest blog that I just put up 2 blogs last night. Read one of the blogs, you know, where it's good factual information that might give you real concrete tips and tools that will help you control your symptoms. Okay. I don't care. I mean, you go to the ICA, go to the IC Network, but really stick to our 2 websites because we're really the best on the web right now. The International Painful Bladder Society over in Europe, that's also a very, very good website. ESSIC is very good. But I don't really want you spending a lot of time in support groups where people are telling bad stories, because as we have learned is the more negative you read, the more quickly your body processes pain, the more depressed and angry, upset you get, your nervous system amps up and the pain intensifies. We're trying to calm things down. So I'd rather you get off the internet and go out in your garden or do something happy that will slow some of those pain messages down in the brain. All right. Last questions. Isabella, do I know when the new non-invasive Hunter lesion test will be available? Do you think that it would be available at most urologists? Is this a urine test? Number 1, it is a urine test. Number 2, it is available in research studies at Beaumont Hospital or Beaumont Health in Royal Oak, Michigan. I don't know if they're doing it in other research centers. I had a way of knowing, but because I work with them, I had to step back from that information to avoid a conflict of interest. You could always call them. And I talked about it actually here in our summer magazine when I reviewed all the research. Here it is. New urine test shows high confidence in correctly diagnosing IC. And that work was done by Laura Lamb, who's an IC researcher with Ken Peters at Beaumont Hospital. So this study was only done at Beaumont, but their next study may have been done in multi-centers. I'm not sure. And I had to recuse myself from being part of that discussion. So how do you find the store? The store is at icnsales.com, or just come to ic-network.com and click on the shop link and it will take you right there. I keep the store off of our main website because I have a divide and conquer strategy for web security. And so our store lives over on a very, very secure server maintained by a security team because it's e-commerce. So they're just in separate locations, but they're connected. They're both IC Network stores. Catherine, I get hundreds of email a day. Hello, Siv from Norway. Speaking as a Norwegian in the United States, it's always nice to talk to other Norwegians. Catherine, if you could right now resend me that email, I will respond to you as soon as we are done with this chat, okay? As soon as we're done. I might have just missed it, or it might have gone into my junk folder. If you could resend it right now while we're on, I can look and tell you if I've gotten it or not, okay? All right. Siv, at some point in time, I'd love to hear about how they're treating IC in Norway. You have one of the biggest IC researchers, Magnus Fall, but I actually think he's in Sweden and not in Norway. Thank you, Lynn. What's the best nonprofit to donate to for IC? The best nonprofit is actually an IC research center. I don't believe in I don't support to any great degree sending donations for IC research to nonprofits. I believe in donating directly to the research center, because when you send it to a nonprofit, some of it is going to get lost in nonprofit operations rather than going directly to research. If you do want to send it to a nonprofit, you have to put a very clear line. This is only to be used for IC research. And also, too, I would strongly suggest that you go to that nonprofit website. And I think we're talking about the ICA here. Their website is ichelp.org. And if you go to the About Us link, which I think is at the bottom of the page, you can actually look at their IRS Form 990s to see how much money they're actually giving to research. Several years ago, I was stunned, and I wrote a blog about it, that they had well over $1 million in income, and they only gave $35,000 to IC research. That was, I think, in 2015. And so, and they improved, because I wrote the blog and it was pretty critical. They did up it to 100,000 the next year, but now it's dropped down again, I think. I don't know. I don't work with them at all. All I have is information gained from their IRS Form 990s. And I just think that if you want to know how that money is being used and if it's really going to research, you need to go look at that form and see if you're happy with them. We don't take donations for research. I give you the company that, the nonprofit that we suggest is the Beaumont Foundation, to support the best IC research center in the United States. Lynn, thank you for purchasing Preleaf from the IC Network. What is the doctor's name at Beaumont? It's Ken Peters, is the chairman of the urology department. Kenneth Peters. And they have a state-of-the-art women's urology center that's northwest of Detroit. Any good specialists for IC in Pennsylvania? Yes, you have Robert Eckenberg, who is probably the top pelvic pain doctor in the United States. And he works out of Bethlehem, Pennsylvania, and New York City. Julie, there are still a small handful of bathroom cards from last week that I have not sent out yet, that I will be sending out tomorrow. I just had to get more from my warehouse, so I ran out at the last minute. So there were a small group of you that did not get them. Feel free to resend your information again. And let's see here, Kathy, Kathy, do you want me to answer this online in this room, or do you want me to answer this privately? Can you reply and tell me on Facebook? All right, I'm just responding to Kathy by email. All right, my good people, if I could give you a hug right now, I would. You are not alone. I get it. I've been there too. And I want you to carry hope in your heart every single day. We are making such great strides forward with IC right now. And if you're going to be diagnosed with IC, thank God it's now rather than 50 years ago when they put you in a mental institute or they told you it was all in your head. That's a whole nother story. All I can tell you is the U.S. government has put over $100 million into ICU research. We are so far past the point of thinking this is mental or emotional. If anybody has the audacity to tell you that IC is all in your head, then what you're going to say to them is, why the hell is my bladder bleeding? That'll shut them up right away. Again, my goal here with these meetings is to make you strong, powerful, informed, confident, ready to walk into any doctor's office, ready to be a proactive and equal participant in your medical care, and if necessary, be willing to kick a little bit of ass, because I think it's okay to kick a little bit of ass when it comes to your IC. And excuse me for swearing, but you know what? As she says in that book, sometimes it's a really good thing to do. And last but not least, would you please vote on Tuesday? Vote for your health care and the coverage of pre-existing conditions. That's all I'm going to say, but seriously, we need every vote out there. All right, my friends, be well. Big hugs from the IC Network here in California. I will see you sometime this week with a drop-in session. Maybe on Thursday. Can't tell you the time, but again, if you like our Facebook page, you subscribe to our YouTube channel, you get a notice when it's going to happen. And last but not least, if you need support, you are welcome to call the IC Network, 1-800-928-7496. We are the only patient support group that actually answers the phone and takes your phone call. Phone calls are answered first come, first serve. And so if you're in the first group to call, the first 5 or 6 phone calls that we get, the odds are you're going to get a phone call back that day. Sometimes we can get through as many as 10 or 15 calls a day, but don't be surprised if it takes 24 hours or a little bit longer to give you a phone call back. But I promise you, we will try to call you back. All righty? All right, my friends, be well. I will talk to you later. And Kathy, I'm calling you right now. Goodbye, YouTube. See you later.